Yes. Maybe. Okay. This patient exhibits on the acute onset psychosis. This patient exhibits acute onset psychosis hallucination that is temporarily associated with introduction of new medication, most likely due to high dose glucocorticoid for asthma exacerbation. High dose glucocorticoid for asthma exacerbation. His psychosis does not appear to be associated with delirium because he is alert and oriented, or any other psychiatric or other medical condition. High dose glucocorticoid, often given for allergic, inflammatory, and autoimmune conditions, cause glucocorticoid may cause glucocorticoid induced psychosis. An example of medication induced psychotic behavior, sorry, medication induced psychotic disorder. Psychotic symptoms typically occur during the first weeks of glucocorticoid treatment, but can occur anytime. Glucocorticoid can cause manic or depressive symptoms. Glucocorticoid can cause manic or depressive symptoms. Okay, it's not brief psychotic disorder and is characterized by psychotic symptom lasts for more than 1 day but less than 1 month. The diagnosis excluded if the symptoms are better by the if the symptoms are better explained by the effects of a medication or medical illness. Okay, if no asthma history, or then can then it is brief psychotic disorder, like if he is not in high dose of glucocorticoid, because brief psychotic disorder psychotic symptom lasts more than 1 day but less than 1 month. Can you hear me? Okay. Okay, it's not option C, medication induced delirium. The core feature of the delirium is fluctuation cognitive impairment. characterized by poor attention, disorientation, psychotic features may be present secondarily, but this patient is alert and oriented, making delirium less likely. Got it? How many features do he has? He has fatigue, poor sleep, two, distracted. Yes, loss of interest, and some sort of weight loss too. MDD. Cancer diagnosis 6 months. Completion chemotherapy, so 6 months, more than 6 months. It's not illness anxiety. There is a one good post in the Reddit today. Like there are some people who is uh, giving like they got 270 and these and that. Have you? Okay, okay. Next. Okay, I am going to explain. Okay. Okay, although fatigue may persist after completion of chemotherapy and anxiety about cancer recurrence is normal, this patient is showing other signs and symptoms that are concerning for MDD. She has she has loss of interest, no longer meeting her friends for lunch, impaired concentration, sleep disturbance, weight loss, social isolation lasting for more than 2 weeks. Strongly suggestive of MDD. This should prompt assessment of depressive symptoms, feeling of worthlessness or guilt, loss of self-esteem, suicidal ideation, recognition of MDD. Recognition of major depression is medically ill patient is important because untreated depression can have major impact on quality of life and can negatively affect treatment adherence and medical outcome. Physicians should not assume that depression is a normal reaction to a cancer diagnosis. Medication should not assume that physician should not assume that depression is a normal reaction to have cancer diagnosis or impairment in sleep, appetite, and energy loss are due to cancer or its treatment. Patients with cancer can be safely or effectively treated with psychotherapy and antidepressive medications. Okay. Okay, he has gained weight, so we need something that may lose his weight. Like bupropion has the weight reducing capacity. Okay, it does not. Okay, all the SSRI are common initial choice in the treatment of MDD. Many patients do not respond. Many patients do not respond to them. The patient has failed two trial of antidepressant. That is important. The SSRI acetalopram and sertraline make it making it preferable to switch him antidepressant with a different mechanism of action. Antidepressant with a different mechanism of action. Because no antidepressant is clearly more effective than others, drug selection is based on factors such as safety, side effect profile, specific depressive symptoms, comorbidity, personal or family history, antidepressant response. Alternate first-line medications include bupropion, mirtazapine, bupropion, mirtazapine, uh, SNRIs, and serotonin modulators, vortioxetine. Bupropion is a norepinephrine dopamine reuptake inhibitor with a distinct mechanism of action from SSRI in that it has no serotonergic effect. It is activating and does not cause weight gain and has no sexual side effect. It would be preferred choice for this patient whose depressive symptoms include hypersomnia and weight gain. Okay, next. Still, so, fatigue, leg pain. He feel tired all the time, like me. He has previously ADHD now, but has not required any medication since school. ADHD is a stimulant, and he's not getting stimulant. Is the reason? Yes. And during college, she received supportive counseling 2 months after being raped. It is another concerning thing. Okay. Full range of. He's not sad. He's just like fatigue. He's just fatigue. It's not bipolar. It's history of alcohol. I think that it is. Okay, no, no, no. You are right. You are right. Okay, this patient history of this patient history of medically unexplained chronic chronic somatic symptoms is suggestive of somatic symptom disorder. Patients with somatic symptom disorder often consult multiple providers and undergo repeated lab testing with negative result. A history of childhood abuse and adult sexual trauma has been consistently associated with the development of somatic symptom disorder. Other risk Other significant risk factors for somatic symptom disorder include female sex, low educational level, history of chronic illness as a child, and exposure to a family member with a chronic illness as a child. Concurrent medical and psychiatric disorder, that is depression, anxiety, and the difficulties with expressing emotions. Alexithymia are also commonly associated with somatic symptom disorder. Okay, I am reading the box of somatic symptom disorder. Somatic symptoms risk factors are female, lower educational level, chronic childhood illness, or family history of chronic illness, childhood abuse or neglect, sexual trauma. Key features: one or more than one somatic symptoms causing distress or functional impairment, excessive thoughts, anxiety, or behavior, time, and energy related to the symptoms, and more than 6 hours of duration. Associated feature: high healthcare utilization, multiple providers, repeated testing, rarely reassuring. Management is scheduled regular visit, not symptom driven with same provider. Limit unnecessary workup or specialist referral. Legitimize symptoms but focus on stress reduction or coping strategies, antidepressant, cognitive behavioral therapy if treatment resistance. Okay. It's due to the nasal decongestion. Okay. This previously well child has been receiving medication for cold for past 3 days. His acute onset hallucination within that period is most likely due to medication side effect. Over-the-counter antihistamine diphenhydramine doxylamine that decreases the nasal discharge has also have anticholinergic properties that can cause confusion and hallucination. Alpha-1 adrenergic agent phenylephrine pseudoephedrine constrict blood vessel decreasing nasal congestion. They can also result in agitation and psychosis versus sympathomimetic properties. In addition, the cough suppressant dexmethorphan, which is NMDA antagonist, can result in dissociative symptoms and hallucination. Side effect of over-the-counter medication may cumulative when used in combination or in excess recommended dose. However, side effects may also have prescribed dose in sensitive individuals. Yes. Okay. All antidepressant can induce mania. All antidepressant can induce mania, with the greatest risk occurring in patients with bipolar disorder. Therefore, prior to initiating antidepressant for a major depressive episode, all patients should have screened for history of mania or hypomania to rule out bipolar disorder. As many patients tend to minimize or have difficulty recalling periods of mood elevation, physicians should inquire about discrete periods of uncharacteristically good or irritable moods, excessive energy, decreased need for sleep, racing thoughts, and risk-taking behavior. This patient history of early onset depression, poor tolerability. In this patient has a history of early onset depression, poor tolerability to a previous trial of antidepressant medication treatment, and a depressive episode characterized by lethargy, hypersomnia, and especially characteristics of bipolar depression should warrant careful assessment. Patients who have major depressive episode meet the criteria for a past manic or hypomanic episode should be diagnosed with bipolar disorder rather than unipolar major depressive disorder. Antidepressant monotherapy should be avoided. Antidepressant monotherapy should be avoided due to risk of inducing hypomania or mania. Okay. Yes, I have created the blog. Let's take a 5-minute break. Okay, I'm coming.